Thank you for joining us today for the webinar. My name is Erica Bloom, and I'm the Product Marketing Manager at Springer Publishing. Today we are presenting Pathophysiology, Teaching and Learning the Essentials for Clinical Practice with Dr. Nancy Tkacs, author of Advanced Physiology and Pathophysiology. Dr. Tkacs has been teaching pathophysiology for advanced nursing practice for over 25 years, drawing on her knowledge of organ systems, physiology, and pathophysiology to provide a strong basic science foundation for advanced nursing practice. As a master's prepared nurse with a doctorate in physiology, she is able to build a bridge between physiology concepts and pathophysiology of disease. Before we get started, I want to mention that this webinar will be recorded. If you miss any portion of the presentation, you can find the video on springerpub.com 5 to 7 days post-event. If you have any questions, please type them into the Q&A box on your Zoom control panel, and I'll bring them up at the end of the presentation. If you forget to ask a question, there will be a brief survey sent at the end of the webinar where you can include your question. Now, without further ado, handing it over to Dr. Tkacs.
There we go. Okay, I'm happy to meet with you today and talk to you about ways of teaching pathophysiology and advanced physiology. I'm structuring the content with first a part on what I talked about in terms of the best ways to structure your content to teach the essentials of pathophysiology that underlie clinical practice. Then I'll go into a section on teaching strategies that I've employed, and I'm sure many of you have also employed, for student success in pathophysiology. And I'll end with a section on how one keeps up with the science that is so rapidly advancing in the biomedical field. So my focus on essentials for clinical practice, I really enjoy the writing of Professor Terry Wu, who is currently at St. Martin's University. And what she wrote is, there's never enough time to teach everything in nursing. So learning to pare down your content to the essentials and delete nice to know information is critical. So I'm going to talk today about the concepts involved in teaching about lung function and lung diseases. And first thing I had to decide was, what are the essential concepts that one must learn to care for the patient with lung disease? Lung disease is near and dear to my heart because between getting my master's degree and getting my PhD in physiology, I worked both in intensive care and also as a visiting nurse in the rural South. And I had so many patients with different lung disorders that when I went back for my graduate training in physiology, it was much easier for me to latch on to these critical concepts because I was picturing patients I had cared for with COPD or with pulmonary edema. So I found that I was eager, after I finished my PhD in physiology, to come back to the field of nursing and teach pathophysiology to help my students make those connections. So I also feel it's important when you're choosing the essential concepts to think of this as chunking the material into big concepts that can then be used for defining where you take your lecture breaks and defining where you find your major objectives and concepts that you want to test your students on. So that is what I have done. So I'll give you examples for the lung as we go through the bulk of this talk. So starting at the beginning, what did I think were the major concepts of lung function and underlying the pathophysiology of lung diseases? So there are 5 here, beginning with an overview of lung structure and function, moving on to compliance, discussing the compliance of the lungs and the chest wall in health and disease, then moving on to airway resistance, then focusing down at the level of the alveolus on gas exchange in the lung, and then discussing lung vascular considerations. So let's move into the first lung concept, an overview of lung structure and function. So in the average adult male, there's a movement of 5 to 6 liters of environmental air in and out of the body every minute. That's if you have a tidal volume of 500 milliliters and a respiratory rate around 12 breaths per minute. And so you're bringing in external air that could have pollutants, it could have pathogenic particles, and the lungs are protected from toxins and allergens and infectious particles by the concept of mucociliary clearance, that process, and by immune cells that are found throughout the airways, even down to the alveoli, that immune cells and mediators can protect against pathogens. So from that normal physiology concept and process, we can see that there would be a vulnerability if the production of mucus is impaired. And you see that in the disorder cystic fibrosis, where there is production of abnormally sticky and stiff mucus. So again, we flip-flop back and forth between a normal process and then a disease that's an exemplar for things that can go wrong. Then you talk about the structures, muscles, and neural mechanisms of inspiration and expiration. So in particular, the neural control through the phrenic nerve of the diaphragm, the descent of the diaphragm being the main activity that causes the negative pleural pressure to drop, the negative alveolar pressure to drop, and therefore filling the lungs with air. So you have those neural mechanisms, and the vulnerability of that is if you have nervous system injuries, if you have a high spinal cord injury that disrupts the connection between the medullary respiratory centers and the phrenic motor nucleus, which is found in the cervical spinal cord, levels C3 to C5. Also, vulnerability to opioid overdoses, which suppress respiration through their action on the brainstem respiratory centers. You have to, as one of the overview concepts, talk about lung volumes and capacities. And so a vulnerability that is often used to illustrate this is the concept of what happens in a pneumothorax. So that's the first big chunk of talking about the lungs. And then as a faculty member in a lecture hall, or as someone writing a book, I want to assess whether or not people are really getting what it is that I was talking about and explaining. So I want to assess their comprehension. So one strategy for this is to insert knowledge check questions throughout the lecture, or if it's a totally online course, in the learning management system for that asynchronous content. You want to base those kinds of questions on your objectives for each concept. And you can, especially in a live classroom, allow students to pair up by twos or threes to briefly discuss amongst themselves and to answer polling questions. Perhaps you're using the students have their smartphones, and you can throw a poll right up on the screen and have them respond to see how many students are struggling with that concept. So an example for this first concept is, what mechanisms protect the delicate alveoli from particulates and pathogens that enter the pathways? So you bring it full circle each time to try to have an increase in student comprehension, and then the chance for students to ask your questions. The next concept for the lung function is the concept of compliance. Compliance of the lungs and the chest wall, because that system works all together in health and in disease. Well, as an organ, the lungs are very compliant. They inflate with a fairly low negative inspiratory pressure, bringing the lung from the atmosphere down all the way to the alveoli. And a particular component of the alveoli is surfactant. Surfactant that coats the lining of the alveoli contributes to lung compliance and makes the alveoli easier to inflate. So there are two vulnerabilities that you have where you can have a disorder of compliance. First of all, disease processes that increase lung stiffness, that make the lungs less compliant. You see this in pulmonary fibrosis. You see this in some of the pneumoconioses, the infiltrative diseases of the lungs. And this will make the lungs hard to inflate. So it will impair inspiration. It'll make it more difficult to take a deep breath in. Also, acute absence of surfactant, which you see in ARDS, and you also see it in prematurity, infantile neonatal respiratory distress syndrome. there's an absence of surfactant, and that makes it much more difficult to inflate the lungs. On the other hand, you have an opposite extreme of lung compliance. The lungs have elastin fibers that aid passive expiration by elastic recoil, so that when you relax the inspiratory muscles, the diaphragm, and the external intercostals, the lungs will retract back to their original size, and that will create an airflow of expiration. So this is a form of vulnerability in that if you have a disease process, such as emphysema, that destroys elastin fibers, the lungs become very floppy, and that impairs expiration. And so you have to have the actions of the lungs that would normally be a passive expiration process allow some areas of lungs to actually collapse. And so this is a problem. The chest wall pulls to a more open size. And that's when you start to see the patient have that barrel chest appearance of the person with emphysema, where there's an increase in the anterior posterior diameter of the chest. So a teaching strategy, a sort of a trick of the trade that I've used to bring the concept of compliance to life is to go to a medical equipment store and buy physical therapy resistance bands. And I buy one that would be of a regular sort of resistance, a regular amount of effort to stretch it. And then that one that's very, very light, that's very easily stretchable, and one that's very, very stiff. And I could have them in my lecture hall, and during the class break, the students would be able to stretch them, and I would have them handle the normal strength band and say, okay, if this is normal, then you hand them the very lightweight band. You say, then, what disease process does this represent? This is something that stretches easily, but doesn't have much elastic recoil. So it very weakly recoils. And I would use that to teach about emphysema. And then comparing the normal strength band with a very, very stiff band that was hard to stretch, but had a great elastic recoil. Well, that's your model for pulmonary fibrosis and the restrictive diseases like that. So the students can actually experience that phenomenon of increased and decreased compliance, which helps, I think, with their learning process, especially for students that have different learning styles. Okay, moving on to the topic of airway resistance. The airways, of course, from your large trachea and your bifurcation into the bronchi, they get more and more narrow. And so as those airways branch and narrow, there are several airway generations where the resistance of the airway is increasing. And so airway resistance tends to be at its lowest when the lungs are very full, because all of the airways are expanded to their largest volume. But then as the lungs empty, then the airway resistance goes up, and that slows expiration. So we see a vulnerability of airway resistance when you have an acute disease like asthma or a chronic disease like COPD. These obstructive diseases narrow and even finally close the airways. And so because of the biophysics of airway resistance, the measurements of peak flow, which is done when you're at a completely full lung, total lung capacity, so that should be the time of the lowest resistance, where you would see that peak flow that patients monitor with their own little peak flow meters, and measurements of pulmonary function testing of forced expiratory flow. The forced expiratory flow maneuvers monitor and help you manage a patient's airway narrowing. And so that's a key biophysical concept for how the lungs are working and how that is monitored. And then also, if we drill all the way down to the cellular level, we can talk about bronchodilators that target key receptors on bronchial smooth muscle to improve airflow. So something I've done in classrooms to bring the concept of resistance to life is to bring different sizes of straws, drinking straws. So if you have a normal size straw that you would get in a soda that you bought at a McDonald's, and you cut it into sort of shorter chunks, And then if you had some straws that were big and fat, like you would use for drinking bubble tea, and you had the students breathe through each of those types of straws, they can easily see that the smaller straw has the higher resistance and it's harder to breathe through, and the bigger straw, and that's what you're trying to achieve with bronchodilators, the bigger straw has lower resistance and it's easier to breathe through that. And then if you want to talk about pediatric and infant implications, you can bring one of those little teeny cocktail size straws that they give you to serve your cocktail. And you can have the students check how difficult it is to breathe through something that's that much smaller. But of course, the airways in infants and young children are smaller than adult airways, and we need to appreciate that in giving clinical care. So that's how I've brought the concept of resistance to life. Throughout the teaching, we like to use pictures to reinforce the concepts that we're talking about. And so showing a picture of a normal airway and an airway during asthma symptoms, where you have the airway being narrowed by the thickened and inflamed airway wall that's full of inflammatory cells and mediators, excess mucus production, and of course, the contraction of bronchial smooth muscle constricting that airway. You can also use pictures to drill down and explain the cellular mechanisms. So what you see on this slide is a bronchial smooth muscle cell, and at the top, we have some receptors for bronchoconstricting mediators. The neurotransmitter acetylcholine that's released by parasympathetic nerve endings will bind to muscarinic receptors on these cells. It will activate a chain of intracellular events that will cause bronchoconstriction. The same thing with leukotriene receptors, the inflammatory mediators that are released during an asthma attack. And then down at the bottom, you see the most prominent bronchodilator mechanism, which is the beta-2 adrenergic receptor, which works through its intracellular second messenger cascade. And that, of course, is the target of a short-acting bronchodilator like albuterol. So I call these kinds of slides that I would present during my lectures a pharmacology commercial. To me, one of the biggest jobs that the pathophysiology course has to do is to provide a platform for teaching the pharmacology course that often is either combined with pathophysiology or immediately follows the pathophysiology. So although I'm not teaching the pharmacology, I'm giving a little sneak preview of things that the students would see once they get to that next level course. Moving on to the fourth lung concept, we're talking about gas exchange in the lung. So the whole job of the lung is to bring oxygen into the body and expel carbon dioxide. And in order to do that, you have to drill down all the way to an individual alveolus and talk about how there's this very, very thin alveolo-capillary membrane between alveolar air and pulmonary capillary blood, or alveolar capillary blood. And this allows rapid gas exchange. So once that gas gets in the body, it has to cross that barrier in order to get to the body cells, to the systemic circulation. And of course, the vast majority of oxygen that enters the blood is going to be diffusing into the red blood cells, where it will bind on one of the 4 binding sites of hemoglobin. So the whole body oxygenation that can be achieved depends on the mix of alveolar ventilation with the blood flow through the pulmonary arteries that is perfusing the lungs. And this gives rise to a couple of different vulnerabilities. First of all, damage to the neural control of respiration. So as I mentioned on an earlier slide, the lungs aren't like the heart. The heart has its own pacemaker, right? But the lungs, in order to have rhythmic inflations and deflations, the lungs are dependent on the central nervous system, neurons in the medulla that project to the phrenic motor nucleus controlling the diaphragm, and also to some of the thoracic levels controlling the external intercostals. And so anything that hampers that neural connection will cause a decreased rate and depth, particularly depth of respiration. And if you decrease the depth of respiration, you'll decrease ventilation coming in each minute to the lungs. So the person will not be able to oxygenate well. If you have anything causing a lack of airflow to diseased lung regions, so for example, if you have pneumonia and you have many areas where the alveoli are suffering atelectasis or collapse, then that area is not going to be ventilated. If you have an inhaled object that blocks airflow to a whole lung, a young child who aspirates a marble or something, then there's a whole lung potentially that's not participating in ventilation. So you won't be able to get good oxygenation of the blood. Also, if you have flooding of alveoli with pulmonary edema or a thickened alveolo-capillary barrier, as you would see in pulmonary fibrosis, you could have impaired ventilation. And so you can use pictures that will help to clarify difficult concepts, processes, and mechanisms. So this is showing a couple of pictures relating to gas exchange in the lung. And so on the left, you see a picture of hemoglobin saturation, which can go from 0, no oxygen's bound to hemoglobin, to 100%, where you have each hemoglobin molecule carrying 4 oxygens. So it's full. And in the top here, we have alveolar air with a PO2 of about 100 millimeters of mercury. And as the mixed venous blood comes through the alveolar capillary, those hemoglobin molecules are loading up with oxygen until you have blood leaving to go to the left side of the heart, bearing an arterial PO2 close to 100 millimeters of mercury. And then looking below, when that blood gets to the tissue, where the tissue PO2 might average 40 millimeters of mercury, then those hemoglobins will unload 1 oxygen apiece and provide oxygen into the tissues. It'll cross the capillary membrane, the systemic capillary membrane, to oxygenate the tissues. And so you'll have a change to a net hemoglobin saturation of about 75% of mixed venous blood. And from there, we can go on to the right-hand diagram, the oxygen hemoglobin dissociation curve, that puts that relationship into the normal physiological context of loading up in the alveoli on the right-hand side of the figure of the curve, and then unloading into the tissues as you go down to lower tissue PO2s. And that relationship shifts, as we know. If there's a change in local pH, PCO2, 2,3-diphosphoglycerate, or changes in temperature, you can have a shift of that dissociation curve to the right or to the left. So these are things that we teach with both words and with pictures. The final big concept that we have for this chapter is the concept of lung vascular considerations. So of course, you have 2 sides of the heart. You have the right heart perfusing the lungs, the left heart perfusing the body. So blood flows from the right heart to the lungs through the pulmonary artery. This is a low pressure vascular system, unlike the systemic circulation, where the left heart has to pump blood all the way up to the head in the upright position, all the way down to the feet and back. So the pulmonary artery pressure averages 25/15, much, much lower than aortic pressure. So this is a low pressure vascular system. And that relates to the fact that there is very low lung vascular resistance. The lungs have many, many branching vessels leading to those alveolar capillaries. So it's almost like a spongy texture where each little tiny bubble has its own capillary. So you have many millions of alveolar capillaries taking this blood from the pulmonary artery over to the pulmonary veins. And you have all of these parallel pathways reducing the vascular resistance. Lung blood flow, however, is positional because it's much more strongly influenced by gravity, and gravity will pull more blood flow to the dependent lung regions. So in the upright position, the bases of the lungs get more blood flow than the apices. So there's a slight mismatch between ventilation and perfusion from top to bottom of the lung, but overall, there is a good enough mismatch to get excellent ventilation under normal healthy conditions. If you have an area of consolidation with pneumonia and areas that are not getting as much oxygen, there is a compensatory mechanism called hypoxic vasoconstriction. And what that mechanism can do is it can help to match ventilation to the proper areas of perfusion and vice versa. So rather than wasting a lot of blood flow in an area that's hypoxic because of collapsed alveoli, those capillaries get vasoconstricted in that region, and that moves blood to an area that's very well ventilated. So there are some compensatory mechanisms to help the body match ventilation to good perfusion. The lung vasculature has certain vulnerabilities. Clearly, it's vulnerable to pulmonary emboli, blood flow from the legs, where you may have formed a deep vein thrombosis, will come back through the inferior vena cava to the right atrium, through the tricuspid valve to the right ventricle, and go and block an area of lung that will no longer be receiving blood flow, will no longer have perfusion. So this is a point of vulnerability in maintaining proper oxygenation and gas exchange. Pulmonary edema, where you have alveoli, some of which are filling with edema fluid, or even thickening the alveolo-capillary interface so that there's less air exchange occurring. And if you have abnormal vascular resistance in the lung vasculature, you'll have people who have pulmonary hypertension. So this can be an idiopathic condition, or pulmonary hypertension can also be seen in newborns. There's an infantile neonatal pulmonary hypertension form. So the normal function is in a good position to match ventilation to perfusion, but we still have pathophysiological conditions. So as I'm ending this part of talking about these processes and concepts and mechanisms, I do want to mention what I think a lot of patients need to hear when you're doing your patient teaching. And I always think of a Joni Mitchell song, which is about the environment, and it's also about a breakup of a relationship. It's called Big Yellow Taxi. And the chorus of that song goes, "Don't it always seem to go that you don't know what you've got till it's gone?" And that's how I think of the relationship between normal physiology and pathophysiology, that a patient with pulmonary fibrosis, what they're struggling with and what the clinicians need to help them to understand is that there was this particular property of the lungs that had to do with how easily they inflate. And now that is gone. And so the management that's provided, in the care that's provided and the teaching that patient needs, is to help them understand that the disease process took something away. And so you are there to help them manage and compensate for that loss. But until then, they didn't know they had it until it was gone. Moving on, of course, we have to consider lifespan considerations. And so talking about what happens before you're born in the development of the lungs. We have an embryonic period where there's just a formation of a simple lung bud, which then starts to differentiate into trachea and bronchi. There is an early phase, 7 to 17 weeks, where you have the progressive branching, growing, lengthening of that bronchial tree. And you start to see type 2 pneumocytes. Now, the type 2 pneumocytes are important for two reasons. First of all, in building a lung, they are the precursor cells for type 1 pneumocytes, which are the very thin ones that form the bulk of the alveolar wall as the lung matures and begins to get ready for gas exchange. And then as you have formation of many type 1 pneumocytes, the type 2 pneumocytes will then progress to their other job, which is to form and secrete surfactant. So you have those stages. You have the 17 to 27 weeks. You start to form more of the lung periphery and even some connective tissue, increasing the vascularization, really having angiogenesis of the pulmonary alveolar capillaries to supply that gas exchange surface. The type 1 pneumocytes appear, and that air-blood interface begins to form. In the 27 to 36 week phase, you start to have more alveolar saccules in the development of the multi-branching airways. And you can also detect surfactant in the amniotic fluid. And then starting a couple of weeks before a term birth, there is formation of mature alveoli, and that proliferation continues for the first several years of life, so that there is less gas exchange surface in an infant or a premature birth, preterm baby, and their body doesn't have as much oxygen demand, so that's sufficient. But as the body grows, the lungs and the alveolar gas exchange area increases in a commensurate fashion. During development, a fetus will have respiratory movements, rhythmic expansion with a descent of the diaphragm. That will help to develop the fluid-filled lungs. Surfactant production will begin at 25 to 7 weeks and will continue. And that formation of alveoli continues robustly after birth, consonant with the growth. So this is a point of vulnerability. For example, if you have a congenital diaphragmatic hernia and abdominal contents move up into the thorax and compress the lungs, that will impair lung development because the respiratory movements won't be able to fill the whole lung. Extreme preterm birth can require exogenous surfactant and respiratory support, and also increase the risk of bronchopulmonary dysplasia. And there is a vulnerability of the lungs to preterm birth, intrauterine growth restriction, severe lung infections in infancy. All of these increase the risk of later life asthma and COPD in adulthood. So this is something that is an overarching concept within pathophysiology, which is the developmental origins of adult health and disease. So this is a current hypothesis. We don't know, if we are adult nurse practitioners, what our patients, often we don't know what their early life environment was like. Physically, in terms of smoking, in terms of other exposures, in terms of adverse childhood experiences. And these things shape life in adulthood in ways that we're just now starting to understand. So that's part of the current scientific progression. Lung aging doesn't have as dramatic changes as the birth transition for babies, but there are still changes, modest changes in pulmonary function testing, less lung elastin, less elastic recoil. So the alveoli get a little bit bigger, start to look sort of on the trend towards emphysema, but not all the way to disease. Modest decrease in vital capacity. There might be some decrease in upper airway responsiveness, greater risk of aspiration pneumonia, which tends to be much more common in older adults, especially with Pseudomonas aeruginosa. And so there are age-related concerns as well. So that's the way I chunk and teach the concepts of lung function. I want to talk a little bit about teaching strategies for student success that one can use, engaging the students through thought questions, case studies, using current events and news releases about new discoveries and therapies, and also encouraging students to help students. Okay, so if you have thought questions that are based on your objectives, you can create multiple choice questions or use questions from a test bank and give bonus points for student responses on an online pretest before the lecture starts to see, if they've read the assigned reading, how handy are they with some of these concepts and some of these jargon words. In a class, you can ask students individually or in teams to do a breakout session, develop some multiple choice questions based on thought questions that you have posed or other questions that come up for them, and give them bonus points for student question development and students answering questions. You can assign more long answer thought questions or small group assignments who then present to a small group that would present their answers back to the larger group. You can use the case studies to ask students to identify a differential diagnosis based on a certain finding on the physical exam or in the history and physical. What would be the evidence basis behind a laboratory testing that might be ordered? Rationale for a particular medication, sort of like an introduction to pharmacodynamics. Why would a medication be used for one of the differential diagnoses? You can ask students to create a patient education handout based on the pathophysiology of a disorder. Something that I frequently used when I was teaching was to have students helping students. So there would always be an online discussion board for each organ system. And students were asked and required to submit their top 3 problem areas from that unit, things that they had trouble understanding, that they want more explanation. Students can get bonus points for answering the questions that other students pose. And often students would share websites and videos that really helped them nail down some of the more complicated concepts. So finally, I think it's astonishing the volume of biomedical science development, and faculty and students need to stay current. The students and all of us for our professional development have to do our continuing education and keep up to date. So it's helpful to scan journals for new studies and clinical trials, bring those to the classroom, bring those to your learning process, try to understand the vocabulary of those articles, and use a concept-based approach to integrate new cutting-edge science. So some new concepts that are pertinent to this topic of advanced physiology and pathophysiology that I want you to be aware of and thinking about. One is the exposome. There are now hundreds, reaching up to thousands of man-made chemicals entering our environment. Some of these are endocrine disrupting chemicals. We do not know the long-term effects of many of these on health and disease. We've seen in real time the evolution of the SARS-CoV-2 virus and the emergence of long COVID. So all of the developments around that have to be followed. There are many ongoing updates in genetics and gene therapies, use of cell-free DNA as a diagnostic agent, both for prenatal diagnosis and for cancer epigenetics, development of mRNA vaccines, which just won the Nobel Prize. Gene therapy for sickle cell anemia has just been approved. And the news story that came out yesterday of a boy with congenital deafness who was just in a clinical trial that restored his hearing at the age of 11. Just referring to things you see in the news and talking those through with students, fellow students, I think can be really an important step in developing this ongoing application of pathophysiology. The development of our understanding of the development of gender identity and the basis for gender affirming therapies. All of these are pertinent for us and for our students. Okay, I wanted to talk a little bit about the book. I was really excited to have this new edition coming out this spring because it's a topic I'm so passionate about. This shows you each chapter starts with a brief outline, followed by something called the clinical context, which talks about the prevalence and incidence of some of the major disorders that will be featured in that chapter, looking both within the US and globally, and then starting down the line of the concepts for that chapter. Each concept section is ended with thought questions to help assess student comprehension. And then an instructor manual is provided for faculty. So this will have a detailed outline, a brief chapter summary, the objectives for that chapter, the key points, which also end each chapter, and a section that I call Connecting the Dots that I wrote for the instructor manual to try to give a quick snapshot of the concepts that are so important and where students sometimes struggle with learning the material of that organ system. It also includes suggested answers to the thought questions and case study questions that are interspersed throughout the book, and additional discussion questions with suggested answers, individual and group assignments that as I said, you can use as breakout assignments or for homework with suggested answers and suggested online resources. So now I will turn it over.
Yeah. Thank you, Nancy. Amazing presentation. Instructors can now request a desk copy of Nancy's book, Advanced Physiology and Pathophysiology. You can go to springerpub.com/Tkacs. And then once the book is published in March, you can share this code with your students as well. And then, yeah, you want to go to the next slide?
Sure.
So before we get to questions, I just wanted to give you all a first look inside our new platform for students, Course Connect. Students who purchase the second edition of this book will receive free access to this new online learning platform. This enhanced e-text experience supports classroom learning and helps students to build, apply, and assess knowledge with interactive learning modules. With study tools like custom flashcards, bookmarking, confidence level rating, note-taking capabilities, and search, students will have all the resources needed to maximize their study and master key concepts. There will be a survey at the end of this webinar where you can comment if you'd like to learn more. And now we can open it up to questions. I did see some questions about this presentation. It was recorded and will be available on springerpub.com in 5 to 7 business days, and there'll be a follow-up email that will have the PowerPoint presentation as well. Oh, sorry. Does the textbook have a test bank?
Yes.
Yeah. And what are you most excited about, or update you're most excited about in this textbook?
I'm most excited about the lifespan considerations. We've changed to a template version for the pediatric and gerontologic considerations so that there's a consistent format for those for every single chapter. And I believe that that will make it easier for the reader to see that same consistent format with the pediatric, for example, starting with embryology and talking first about congenital and genetic disorders, and then moving to disorders that are more common in infancy versus those that are seen in older children. So I think I was really happy to flesh that out in a new way, but particularly to add more embryology and more content on pre and postnatal influences on later life organ function. As I said, now that we're learning more about the developmental origins of health and disease, to put that in that context. And then for the gerontologic section, to look at the normal expected structural and functional changes in older adults, and then look at the disorders that are more common or more severe in older adults. So I'm excited about that. I'm excited about the new science, a case study on gene therapy for sickle cell, the discussion of gender identity. We've added content on physiology and pathophysiology of pregnancy. So many important concepts and content that I tried not to make the book a lot longer, but I tried to add some things that will really add tremendous value to this edition.
Amazing. We have 2 more questions I think we can get to. Is the book mapped to the new essentials during practice?
The course that I taught was always mapped to the essentials, and the content does not change in terms of advanced physiology. I think that where you see changes is in the science of the pathophysiology of the major diseases, but the essentials does not go into that type of granular level in the way that the book, the changes here are more related to those aspects rather than the big things covered in essentials.
Yeah. Any thoughts of the best length of lectures for each chapter? It says it's always a struggle to lecture on the deep level of content, and any tips to bring concepts to life in distance learning environment?
Oh, great questions. Great questions. Yes, for years, I gave 4-hour lectures, an hour, one organ system a week, except for the brain and endocrine, which did take a week and a half each. And then I had to compress down to 2 to 2.5 hours. And I found that focusing on these large concepts and giving some applications within breakout room times. So I taught first in a large lecture hall and then online, where I had recorded asynchronous lectures that had to be kept pretty short. And that's where I did most of the chunking. And then we had some synchronous online time, which was used to flesh out more answers to the questions on concepts the students didn't understand, and having work within those breakout rooms that brought more on the case studies and applications, so that it was making the most of the asynchronous time in lecture and then the synchronous time in guided discussions. Hopefully that answered the question.
Yeah, amazing. Thank you. There were just some questions about requesting an instructor review copy. When you go to the product page, you'll see a button that says request desk copy, and you'll fill out the form. And also in the survey after this, you'll be able to say that you're interested, and a rep will reach out to you. And then also just to discuss the essentials again, we have a map. We mapped the AACN essential domains in each chapter, and that's going to be available on Connect, our online platform. And I think that's it for now. Thank you so much, Nancy.
Okay, it's been a pleasure. Thank you.
Thank you, everyone, for attending.